So last time we finished a couple of shock states. We need to just talk about cardiogenic shock quickly. There are some key differences with cardiogenic shock. I promise Tegri's working now, but
Do it.
Not if you have the wrong browser.
huh?
If you have the wrong browser, it doesn't work.
Tegri's working.
I mean, but at home.
Oh, okay. But there's an app for that. Did everybody see I put a demonstration on how to get Tegrity on your phone. So you have to generate a code. So, but good. So yeah. But anyhow, so I was just commenting on all the fun stuff. Tegrity's working. Cardiogenic shock has a few differences that you need to be aware of. Remember that septic shock and hypovolemic shock are very similar, but the cause is different. But at the end, pretty much it's the same, but for different reasons. So the problem in cardiogenic shock, just remember it's called cardiogenic shock. There's a problem with the heart. And in hypovolemic and septic shock, there is not a problem with the heart initially. The problem is with usually fluid volume and infection. But with cardiogenic shock, the heart has lost the ability to effectively pump. So you can kind of think of this as just severe heart failure. The heart can't pump for some reason. The most common cause is an MI, so there's been a massive MI. Lots of cardiac tissue has died and has lost the ability acutely to pump blood. And of course, anything that would cause cardiac arrest, like these deadly rhythms, VFib, VTAC, will cause stuff. No, it gets hot. It will cause the heart. Excuse me, I've been very distracted. These rhythms are within the heart, so the rhythms cause the heart to go into cardiogenic shock. Because the heart is unable, for that reason, VFib, VTAC, to effectively pump blood. So there. Well, VFib, VTAC, the VFib is not a perfusing rhythm ever. VTAC sometimes is, but not for very long. But just remember that those causes are within the heart, so that's why it's called cardiogenic shock. So for some reason, usually myocardial damage and ischemia, so the heart has lost the ability to pump because it's become ischemic and it doesn't contract like we want it to. Cardiac output falls, and therefore we can have signs of heart failure, congestion into the pulmonary vasculature, and you have tissue hyperperfusion. And just like with hypovolemic and septic shock, you go into anaerobic metabolism. All right, so lactic acidosis can occur. So annoying. People. Spoken like a nurse, right? So here are your manifestations. Realize that some of these are going to be very similar or the same as hypovolemic and septic shock, but some things are different. For instance, you might have JVD. Well, JVD tells us that maybe you have fluid volume overload or something like that, but this person, just think of it, has gone into acute, severe heart failure. So therefore, you will have the backing up because the blood is not being ejected, so it's congesting. You have some respiratory symptoms, of course, because of the congestion. Decreased urinary output because of decreased cardiac output. But the patient actually, these things are really key here. So the person doesn't have a problem necessarily with fluid volume status. That's not the problem. The problem in septic and hypovolemic shock is fluid volume status, right? But with this, the patient may actually have fluid volume overload. So in this patient, you may see edema. Let's think about heart failure, right? The CVP might be elevated. Remember, the CVP tells us about fluid volume status, right? So it may be falsely elevated, but it's elevated because the pressure is increased in the right side of the heart because it's congesting, right? So even the person, if they're not really fluid volume overloaded, they may still have a high CVP because the pressure is higher in that right side of the heart. Remember, that's where CVP is measured, on the right side of the heart. Pulmonary artery wedge pressure, that's very similar. The pressure in that pulmonary artery is increased because there's congestion, right? The left ventricle is not ejecting, so it's congested. All right, so these things are key, right? JVD, edema, increased CVP, and increased pulmonary artery wedge pressure. Those are going to be different, opposite in cardiogenic shock, okay? Cardiac enzymes, of course, that'll tell us if the patient had an MI. We can look at if there's infection or if there's whatever is going on. Lactic acid we talked about, it results from anaerobic metabolism. So, of course, we're going to try to treat the underlying cause. Often this is an MI. These are, again, are those medications, the vasopressors / inotropes, or the medications like dobutamine, Levophed, and things like that increase the blood pressure, increase contractility, to increase cardiac output, right? I've already mentioned these things with heart failure, I think. Obviously, a priority nursing diagnosis is going to be decreased cardiac output, ineffective tissue perfusion, things like that with shock states. It's key to assess fluid volume status in a patient that is in shock. So if the patient is hypovolemic, we want to fill the tank first, right? So we need to assess if this patient needs fluid before we start giving them medications to increase their blood pressure. Hemodynamic monitoring. Remember, we started using those fancy terms like hemodynamic parameters, right, which includes vital signs plus some more stuff. And there's the hemodynamic monitoring, which I'll briefly go over, that gives us those numbers. All right. So these next two slides really end up confusing students. But what I want you to hear me say right now is to listen to what I'm saying. Don't try to understand anything on the chart. I'm going to tell you exactly what you need to know on here. It's been my goal for a while to summarize this, but some things I just don't get around to. So just listen to what I say about this, and I'll tell you what you need to know. So I'm going to tell you quickly about adrenergic receptors, because these medications that I've been mentioning, like Levophed and phenylephrine and dobutamine, dopamine, work by activating or inhibiting these adrenergic receptors. So therefore, you have to know what these these receptor sites do. Okay? So what I will have you do is think about alpha 1 and alpha 2 together. Okay? Just think about alpha. When we think about alpha, we think about mostly the periphery. We think about the vessels. We think about action on the blood vessels. So either these medications that act on alpha receptors are either going to cause vasodilation or vasoconstriction. Okay? One medication that you already know is clonidine, right? It works on alpha, and it causes central venous vasodilation. That's how clonidine works. It works very fast. The medications that we will talk about will cause vasoconstriction, because that's going to increase cardiac output and blood pressure. All right? So just know that, okay? Alpha works, we just think about the blood vessels. It does have some action on the heart. See, things are here and there about things, but mostly on the blood vessels. You have to think about beta 1 and beta 2, because you have to remember how beta blockers work. You know, they can cause wheezing and bronchoconstriction, but also the medications that increase cardiac contractility work on beta, but work on beta 1. So you can, I'm not going to ask you what the difference between beta 1 and beta 2 is, because that's what a low-level question, right? So just so you know, you have one heart and two lungs, all right? So beta 1, beta 2. When I think about beta, I think mostly about action on the heart itself. You do have beta receptors in your blood vessels too, but the highest concentration of beta receptors, talking about beta 1, are in the heart muscle. So therefore, if we act on beta 1 with these medications, we increase contractility, increase heart rate. The direct opposite of what a beta blocker would do, right? So this is a beta agonist. Now, I'm not going to ask you if it antagonizes or agonizes, right? Because it gets confusing. It doesn't matter. Just remember it acts on it, okay? Because actually you agonize beta 1, but you antagonize alpha. works to get the effect. But whatever, it doesn't matter for our purposes. So think mostly about this beta 1 and how it increases contractility and increases heart rate if the medication that we're using works on it. Okay. We also have dopaminergic receptors, and these actually, some of the medications that we give can actually cause vasodilation when we give them, like dopamine. We can give dopamine at a low dose, dopaminergic receptor, right? So we can give that medication, and initially at a low dose it can cause vasodilation, but as we increase the dose it will cause vasoconstriction. Okay? So I hope that you underlined a few things as what I just said and circled some things and then crossed some other stuff out. All right?
Low dose was vaso.
No, look at this next chart. All right? So, this is really confusing to you, but I'm going to tell you what it means. All right, so here are your medications. All right? What this chart is telling you is the mechanism of action of these medications. Okay? So, let's just look at dobutamine. So, this is a general dose of dobutamine. Tia's patient had dobutamine, right? And we talked about how... Is Tia? Oh, there you go. Your patient was on dobutamine, right? We talked about how it works. So, I think that your patient was on 7, for most of the day, 7 to 10 mics. Yeah, 10. So, what I'm saying here is that dobutamine has 0 dopaminergic action. Okay? That's what that means. What I'm saying here is that dopamine has very little alpha action. Mostly, dobutamine works on beta 1. So, dobutamine works how? Increases heart rate, increases contractility. Mainly, that's how it works. This last column tells you how much of an arrhythmia potential the patient has. These medications come with a side effect of dysrhythmias. We're stimulating the heart to beat faster. We're stimulating the conduction in the heart. Then we have a risk of dysrhythmias. Okay? So know that this has a moderate to low dysrhythmia risk. And like I said, with dopamine, things happen differently based on the dose. But what this is expressing is that the higher the dose is, the more effect we get on alpha and beta. Okay? So just realize that. It doesn't have any action on beta 1. Lots of action on the dopaminergic receptors. That's dopamine, right? So it causes a lot of vasoconstriction, and it causes lots of increased contractility and heart rate. So that's how it works. That's what I'm telling you is how it works. Epinephrine, which you've heard of, it can be given as a push in a code situation, but we can also hang it as a drip to give to a patient to keep their blood pressure up. So it has more beta action than alpha action. It doesn't have any dopaminergic action, and it has a high risk of arrhythmia. Okay? Is this making sense? Norepinephrine, you've heard of, it's Levophed. So, again, it's dose dependent. So you see that it doesn't work any on beta 2, so you shouldn't have any respiratory side effects. And it doesn't work any on the dopaminergic receptors. What's the only one that works on dopaminergic receptors? Dopamine, right? So therefore, especially at high doses, norepinephrine is going to work mostly by vasoconstriction to increase blood pressure and cardiac output, and somewhat on the beta 1 receptors by increasing contractility and heart rate. It has a moderate risk of arrhythmia. Phenylephrine, which is also called neosynephrine, this is the stuff that you shoot in your nose as a decongestant, right? Because it causes vasoconstriction. But when you give it intravenously, it's much more potent, right? So this medication, it's unique because it works only on alpha. No beta action at all, no dopaminergic action. And because it doesn't work on beta, it has a very low risk of arrhythmia potential, right? You guys following me? Mm-hmm. So so you can see that some really stand out. Phenylephrine stands out. It only works on alpha, so there's no risk of tachycardia increase or an arrhythmia. Dopamine is the only one that works on dopaminergic receptors. Okay. Hopefully, I'll go through and eventually make this a little more simple too. But hopefully, I've described it so that you can understand it. I've told you what you need to know about these charts. Okay.
Can you real quickly go over dopamine and the dopaminergic again, just real quick?
Yeah. So I mentioned at low doses that dopamine, when dopamine is used at low doses, the dopaminergic receptors actually cause some vasodilation, low doses. But as we get more and more dopamine, as we get up in this 2 to 10 microgram range, it's going to cause vasoconstriction over here. Oh, so that's how it works. Okay. Some of you might have seen an art line, maybe not. I don't think any of my people have had an art line yet. But I've mentioned an art line and how an art line gives us a continuous, perfect blood pressure. It's a catheter that's placed inside of an artery. Usually it's the radial artery, and it's connected to the monitor. And we can see this waveform on the monitor. It's just a wave after wave after wave after every heartbeat. So this gives us a perfect measurement of blood pressure. And this is usually used only when the patient is on those vasopressors, like being Lefran and Levofed, because we need to keep a very close check on what their blood pressure is so that we can change those doses as necessary. What else? It'll give you a map. So when you're giving the patient these medications, usually how they're ordered is, maybe the physician will write, start with dopamine at 5 mics per minute and titrate it to a MAP of 65 or greater. That's the order, and you go with it. So you start the Levofed and start it at 5, and the patient's blood pressure, their MAP is still 60. Give it a few minutes, it's still 60. Start at 5, what are you going to do? Increase it. It's your nursing responsibility to change the dose of this medication, because that's how the order is written. So when the MAP is not 65, we need to do something to get it to 65. The patient must have a MAP of 65 to maintain adequate cerebral perfusion. Right? Is that right? So if the patient is on a pressor, the patient is well hydrated. If we need to get their blood pressure up, what do? Increase the dose, right? If the patient is, and I've said this before, if the patient is in hypovolemic shock and is acutely hypotensive, and they need fluid, you give them fluid first, right? Fill the tank before you start the engine with these medications, right? This is the heart is the engine, so you start the engine with these medicines, but you have to fill the tank first. So make sure the patient is well hydrated before you go asking for orders for vasopressors. So this is a type of hemodynamic monitoring. It's an advanced monitoring. And also, we've talked about all these numbers. Pulmonary artery wedge pressure, pulmonary artery pressure, cardiac output, EDV. All these numbers come from this PA catheter. So the PA catheter, the brand name of it is a Swan-Ganz. That's what most people will call it. It's inserted inside of a central line that we often call an introducer. And the medic in the line is put into the subclavian. Sometimes they put it in the IJ, but whatever. It goes into the superior vena cava, right atrium, right ventricle, and then the tip of it, right here, this tip, sits in the pulmonary artery. What is your first thought about this? It's very invasive, right? Extremely invasive. So the patient is at high risk for infection. The patient is at risk for dysrhythmias because you're putting a foreign object inside of the heart. Well, we don't put it in, but we manage this. So the patient is at increased risk for dysrhythmias because there's something inside of the heart irritating it. Right? This is a better picture. You can kind of see real close how it goes through. Right? And on the tip of this is a little balloon, and it's blown up with this syringe that attaches to this port. And when air is pushed into that, this balloon blows up like the tip of a Foley catheter. It's much smaller, but that's how it works. And when that is blown up every so often, that's how we get the pulmonary artery wedge pressure, because this balloon is wedged in the pulmonary artery, and we get pressure while it's occluded. Okay? So that's just how we get all those advanced numbers. All right? The machine does all the calculation for you. Any questions? in your book, I think there's a table about a PA catheter. Read over where the level of the transducer should be, how to level and properly position the patient when they're getting advanced hemodynamic monitoring with PA catheters or heart lines. All right. So try to find the term phlebostatic axis. Right? Phlebostatic axis. Also, last time I kind of forgot to stress the topic of ejection fraction when you're talking about heart failure. The PA catheter measures ejection fraction, but the echo does as well. But just remember that the lower the ejection fraction, the worse off your heart failure patient is. So us here with a normal heart, we should be ejecting at least 50% of our end-diastolic volume. The end-diastolic volume is how much volume is in the left ventricle ready to be ejected at the end of diastole, at the end of resting. So ejection fraction is what percentage of the volume of the left ventricle was ejected into the aorta.
So that's like 1/3. Is it in this?
Half.
It's
Half. We want an EF to be at least half.
I thought it said 2/3 of the blood that was in the left ventricle stays in, it doesn't all get pushed out. So that would mean 1/3 went out.
Right. If you have an ejection fraction of 30%, you have heart failure.
Oh, I see.
Yeah.
Okay,
Yeah.
Thank you.
Yeah.
Okay.
So, ejection fraction. Just know what it is, and that the worse your patient's heart failure is, the lower their ejection fraction is going to be. So the left ventricle might have a lot of volume in there, but the muscle is unable to pump it out, so you get a low percentage of the volume pushed out of the body. Okay. Respiratory. So I think what we'll probably end up being able to get through today is ventilators, and that's okay. But we'll just go as far as we can. These terms you have looked up, and you will be ready to understand what I'll be talking about as we go through. So, a quick overview of the pulmonary system. We looked at the heart real quick, but let's go back over and know what makes up the respiratory system. Just an AMP review. So realize that the respiratory system is comprised of these things. So you have the major organs, and then you have the conducting pathways. So the major organs are basically the lungs, the plural, right? That's the organs really of the respiratory system. The conducting airways are the passageways that get the air to the alveoli, to the lungs. So the nasal passage is even part of the respiratory system, right? So the respiratory airways is where the exchange happens. So remember that the exchange of carbon dioxide and oxygen happens where? In the alveoli, right? So I said bronchioles because sometimes the bronchioles have alveoli attached to them too. But just generally realize that the alveoli is where gas exchange happens. Remember the flow of blood through the heart and the lungs, and obviously they are connected. And that the pulmonary artery is the only artery, right, that ejects unoxygenated blood, or that carries unoxygenated blood, and the pulmonary vein is the only vein that carries oxygenated blood. So, and remember that there's a difference between ventilation and respiration. Ventilation is simply the movement of air in and out of the lungs. Just because air is going in and out of your lungs doesn't mean that you're respiring. So respiration, when the person is respiring properly, gas exchange is happening. So we'll talk about this. This will make more sense later, in that the patient can be ventilated, but they're not oxygenated. All right. Thought this was a nice, pretty picture, nice and colorful. Really quiet out now. So let's talk about mechanical ventilation. A lot of you have seen or had patients on a vent already. And before before today, what I asked my people to do is simply act like a robot and write these numbers down, okay? But from today on, you won't act like a robot. You actually understand what is happening with how your patient is interacting with the ventilator. So realize that when we talk about mechanical ventilation, it's artificial, right? Obviously. And to have mechanical ventilation, the patient has to have some sort of airway. So an artificial airway, an ET tube, a trach, okay? We can also ventilate a patient with just a tight-fitting mask. Why would a patient need mechanical ventilation? Well, if they have respiratory or ventilatory failure, if the patient is hypoxemic, even if you give them supplemental oxygen, and if the patient is breathing too hard, too fast, eventually they will stop breathing. So we need to get them ventilated before the patient codes. Remember from AMP that our natural respiration is a negative pressure system, right? Inside of your chest is negative pressure, and when your diaphragm falls, it creates negative pressure in your chest cavity and pulls air passively, very nice and easy, passively into your lungs. With a ventilator, it's the opposite. So the patient is getting air by air being pushed into the lungs. It's not a natural process. The natural process is for a diaphragm to fall, negative pressure, and air is pulled in, that nice and easy. But with this, it's somewhat violent. It's positive pressure. It's not natural. I talked about, invasive and non-invasive. So the artificial airway, like a trach or an endotracheal tube, or we can use a mask. Here's some nice pictures. So you guys have seen trachs before. Lots of you have done trach care. Everyone has practiced trach care. So there's a trach. All right. So the ventilator can be attached to that so that we can ventilate the patient. The patient may also have what we call an endotracheal tube. So this tube, this breathing tube, is put in just past the epiglottis and sits there in the trachea, and then a cuff is inflated, a little bulb, to keep it occlusive so that air goes in, hopefully to decrease also the risk of GI contents and things going into the lungs, which we do not want to happen. The esophagus is right there. Okay? You're going to see this type of ventilator most likely. This is the type of ventilator that is used now. Everybody will do their ICU portion at the med, so this is the vent that you will see. And so the machine attaches to the patient. You see a lot of numbers on the screen. The settings are down here, and the patient's measurements are numbers. What the patient is doing is at the top. When the patient is on a vent, they will have inline or Ballard suction. So there's none of this, take them off the vent, put sterile gloves on, and suction. That doesn't happen when the patient is on the ventilator. So this is an inline suction, and it maintains sterility because the catheter here is within a sterile little bag. So some of you have seen this. So just realize that when the patient is on the vent and being ventilated, they will have Ballard or inline suction to decrease the risk of infection. All right? Everybody become very alert right now. Okay? This is going to confuse you, but I'm going to do my best to not confuse you. So, you have ventilator settings, all right? So there's a mode. It's the mode in which the vent is set in. The three that I will talk about, the three most common are assist control, SIMV, and spontaneous, or some people call it CPAP. Those are the three modes that your patient most likely will be on when they're ventilated. The ventilator, okay? The patient will have a set rate. How many breaths per minute is the vent going to deliver to your patient? Usually you see between 10 and 16. It's a normal set rate. The ventilator will have a set tidal volume. How much oxygenated air is being pushed into your patient? Generally, we will see a setting of 400 to 600 milliliters. That air is measured in milliliters. Sometimes it's lower. Usually it's not higher than 6 or 650. You can calculate this based on a person's weight, but weight doesn't always tell you how big the lungs are. The person may just be large. That doesn't mean that their lungs are really big. So the human lungs, generally, with just regular respiration, that's about how much goes in and out. The tidal volume. Remember that maybe the tidal volume? Air goes in and out. Think about tidal wave goes in and out, right? Pressure support is extra pressure that is exerted on inspiration. Okay, so extra pressure on expiration. Our airways are fairly large in comparison to an ET tube or a trach. Has anybody ever tried to breathe through a straw? Probably. It's not easy, is it? You know? So this person's breathing through a straw. So they need extra pressure to help the air get into the lungs. So that's pressure support. Usually you will see this at 10 to 20. Pressure support and PEEP are different. You might have heard of PEEP before, I don't know, but pressure support is pressure exerted on inspiration. PEEP is positive in expiratory pressure. Positive pressure support is exerted on inspiration. PEEP is exerted on expiration. PEEP is a little extra pressure during expiration to keep the alveoli open throughout the ventilatory cycle to promote the exchange of gases. Our body gives a little bit of natural PEEP. It's called our sinuses. So as we breathe out through our nose, there's a minute amount of pressure that our lungs need. A little bit of PEEP to keep the alveoli open. Your alveoli should never be collapsed because that's called what? Atelectasis, right? So this prevents atelectasis and promotes gas exchange.
So does that mean when the patient is they're not expiring on their own, the machine is making them expire, right?
They will expire on their own.
They will expire
Yes,
on their own.
yes.
Okay, so while they are expiring on their own, a smaller amount
A
of
small
air
amount.
is going
It's
into
measured a
the
little bit
lungs.
differently. Well, actually, but it's a very small amount of pressure. Sometimes this is measured in centimeters of water, but it's pressure. So just know that there's a small amount of pressure exerted. We can increase this to 20 if we have to. That's a bad situation. But exactly, you said it right. There's a little bit of pressure on expiration, a little bit of resistance. Yeah. Promotes a little bit of resistance to keep the alveoli blown open so that atelectasis doesn't happen and gas exchange doesn't stop. Another setting is FiO2. This stands for the fraction of inspired oxygen. How much of this air, 4 to 600, is oxygen? So remember that room air is what? 21% oxygen. All right, at sea level, room air is 21% oxygen. We can give the patient up to 100% oxygen. That's a lot, right? If the patient requires 100% oxygen, they are in bad shape. All right? So realize that the ventilator can give between 21 and 100% FiO2. I'm not going to ask you to calculate anything. How much of this is FiO2? That doesn't matter. Okay? So those are the settings that you will see on the vent when your patient is in AC, SIMV, or spontaneous mode. Any questions? Just know what the settings mean.
It is more under machine to look for.
Speak louder.
Can we just, in the ventilator, can we see this wall
Yep,
there
yep.
and the way?
The settings are going to be right here. All right?
Do we set it or the doctor set it?
We assess. All right? Either the physician or the respiratory therapist determines what these settings are. All right? Depending on the facility. All right? So let's talk about these three modes of ventilation. I'm going to explain to you how the patient and the machine interact. This is important to know. I put these in order of most support to least support. All right? So let's talk about most support first. So when the patient is on assist control, think about this as most support. The ventilator is going to give a set number of breaths per minute, maybe it's 12, right? And it's going to deliver maybe 500 milliliters of air. For all 12 of those breaths, the patient's going to get 500, no matter what. All right? The machine's going to make that patient take 12 breaths a minute with 500 of tidal volume. They'll also have some PEEP and they won't need pressure support here, but they'll also have some other settings, FiO2. But the key with assist control is that when the patient initiates a breath, so the machine will give a mandatory 12, maybe it's at 16, whatever, the setting. But the patient can breathe over the ventilator. They can breathe extra if they want to. If they're not too sedated or whatever. So if the patient decides, well, I want to initiate my own breath, so they begin to inhale, the machine kicks in and takes it over. It makes them take that 500. So the machine comes in and assists that breath. It controls the 12 and it assists those extra ones. And it turns it into a machine breath. The patient initiated it, but the machine took it over and did what it wanted to do. Does that make sense? Next, I'll talk about spontaneous, because SIV is a combination of the two. Spontaneous, think about the least amount of support. This patient will not have a set rate. This patient will initiate all their breaths on their own. So the patient wants to breathe 20 times a minute, the machine says okay. The patient wants to breathe 5 times a minute, the machine says okay. It might make some noise, but the machine is going to, the patient will breathe as many times as they want. But the key with this is that the machine will never deliver tidal volume. It will not give them a preset tidal volume. The patient determines how much they want to take. So if they want to decide to take 2,000 milliliters, they can. If they want to take a little measly 200 breath, they can. Right? It doesn't, the spontaneous, there's no set tidal volume, and there's no set rate. SIMV is a combination of the two. So still with SIMV, there will be a set tidal volume and a set rate. Let's just say 12 again. So let's say it's SIMV with a rate of 12. And so the machine will deliver to that patient 12 breaths per minute with 500 tidal volume. Let's say that's the setting. Again, like all of these, the patient can always initiate a breath on their own. But with SIMV, when the patient initiates that breath, it's a spontaneous breath. They can determine their own tidal volume. So for that 13th breath, they can take 200 if they want to. But with the sys control, if they want to take that 13th breath, it's going to make them take 500. Does that make sense? Do you see how this SIMV is a combination?
So on spontaneous, is it only like helping push the air in?
Exactly. With spontaneous, they will have some pressure support. And with SIMV, they will also have some pressure support. Yep. The patient is doing most of the work here on their own. We might just be giving a little bit of oxygen and a little bit of pressure to overcome that little straw they're breathing through. Good question, Tim. In most hospitals, I think that they use these settings in this order. They'll start with the sys control. The patient needs the most support. They'll wean them down to SIMV. The patient does more, has more control over what's going on. They'll get them to spontaneous, and then they'll eventually take them off and extubate. But, you know, at the med, what we see there is that the medicine doctors, they like to use the sys control, and all the surgeons use SIMV. You know, whatever. It's just what they do. They buy into different research. So, but just realize, most support, moderate support, least support. A big nursing responsibility with mechanical ventilation is assessing for and preventing complications. Nothing but complications come about because of ventilation. I mean, you know, hopefully, we are doing this for a purpose to oxygenate our patient, but lots of complications come about because of mechanical ventilation. One of the top things that we think about is VAP, ventilator-associated pneumonia. We have, with this breathing tube, have altered the natural airway. The airway protects itself with the epiglottis, cough reflex, and all that stuff to keep bad things out of the lungs. But because the airway is sitting here, the epiglottis cannot close. You see that? The epiglottis is right there. So the epiglottis can't close, so the airway stays open and is connected to the upper airways, and this is the esophagus, so the gastric contents can reflux and come down into the lungs. Not good, right? We do have a bulb here to help prevent some of that, but we also have nursing interventions to do so. The number one intervention is very simple. Head of the bed. The number one intervention to prevent VAP is keeping the head of the bed at 30 degrees. So if your patient is on the vent, does not have spinal precautions, like Brooke's patient, right? Was it your patient? Who? Yanon's patient had spinal precautions, so she was laid flat, right? If your patient is not on spinal precaution, is on the vent, they must be at 30 degrees, unless you're turning them or whatever, but 30 degrees, okay? That's the number one evidence. These are in no specific order, but also when the patient is on the vent or has an airway, artificial airway, they need to have mouth care done every 2 hours. And then CHG is chlorhexidine gluconate. So this is the same chemical that's in surgical hand scrub, but it's a much lower percentage when we put it in the mouth. So chlorhexidine would be done every 8 hours. So for every, third Q2, it should be done with chlorhexidine. But every Q2, we can just use our little swabs here with the material that comes in them, or you can, use whatever your facility wants you to use. I say frequent suctioning. I think I want to change the term frequent to when applicable. You don't want to suction just routinely, frequently, just for the heck of it, because it causes trauma to the airway. But you want to suction when it's indicated. Always suction, especially when it's indicated. So if the patient is coughing or has adventitious breath sounds, wrong type, you maybe suction, or if they're coughing up secretions. You want to get it out of there. Because when the patient has a breathing tube, number one diagnosis, ineffective airway clearance. They can't effectively expectorate because this artificial airway is there. Another thing that we can do as nurses to prevent VAP is to make sure that every patient that has an artificial airway has 2 suction setups in their room. In every ICU room, there should be at least 2 suction setups, but it doesn't always happen. So if you notice that you walk into your patient's room, they're on the vent, there's only 1 suction setup in the room, what should you do? Find another one. Okay? You go find another one. And we want to have 2 because 1 suction setup is designated only for airway suction. The other one is for everything else. The mouth's very dirty. We suction strange things with yonkers sometimes, So we don't want to contaminate the airway with those things. So the airway is, in theory, sterile, right? So we want to try to keep it as clean as possible. The number one thing to do that will prevent VAP is getting the patient extubated. So we always want to make sure that our patient is not over-sedated, so they can be extubated if necessary, or if ready. So always continuous assessment for the patient's improvement and hopefully close to extubation, the breathing tube being taken out. Another complication is barotrauma. Trauma to the airways. This can happen for a few reasons, but remember that the ventilator is working with positive pressure. Normal respiration is with negative pressure. It's nice and easy. So because the machine is pushing in a lot of pressure into the lungs, there's a risk of causing trauma to the airway. This can cause pneumothorax, which we will talk more about later, basically a collapsed lung to the air, or some subcutaneous emphysema that is air in the subcutaneous tissues. Okay. A measurement on your ventilator, one of the measurements is called peak pressure. P-E-A-K, peak. Peak like the top. Don't get this confused with PEEP. Even I say it wrong sometimes because they're such similar words, but peak and PEEP are different, very different. So PIP, peak inspiratory pressure, you can call it the PIP if you want to. This is a number that is measured, and it tells us how much pressure it takes for the machine to push the air into the patient. So the higher this number, the more worried we get, because there's more pressure in the airway. The more pressure we have in the airway, the more risk we have of barotrauma, of blowing a lung, you might say. PIP is assessed continuously, really, but it's documented every 2 hours. We want to know what our patient's PIP is every 2 hours. It's the pressure that it takes for the machine to push into the air into the patient.
Is that another reading that you see on the line?
It's a reading, it's a measurement. It's not a setting. This is a measurement. Yep.
Could an increase mean that you need a suction?
Very good. Yes. So if there's increased pressure in the airway, you first would think about, is my ventilator tube being kinked? Is the patient laying on it? Is their position wrong? Do they need to be suctioned? So usually if I have an acute rise in PIP, I would just suction my patient. Hopefully that will fix it. Often it does. Good. Make sure that the patient's respiratory status is either improving or staying the same. And they will, of course, this patient will have Q1 hour vital signs, which would include oxygen saturation. We'll talk more about the signs of a pneumothorax later. But know to continuously assess for signs of an pneumothorax or subcutaneous emphysema, which is manifested by crepitus. Any questions about that? The machine also can cause the patient to have decreased cardiac output. Because we're increasing the pressure in the chest cavity, what else is in the chest cavity? The heart's also there. So if we, in the great vessels, so if we increase pressure on that, you decrease filling and you decrease preload. Because there's pressure there, so it can't get to the heart like it's supposed to. So the patient has increased intrathoracic pressure. And this, I think I just said all that. So you have decreased preload, so therefore there's less volume to be ejected. So the risk for decreased cardiac output. Continuous assessment, of course, to make sure that the patient is maintaining or is hemodynamically stable, and assess continuously for signs of decreased cardiac output. So just continuous CV assessment, right? And of course, make sure that we are assessing to see if our patient can be extubated, if they can get off the vent. That's a continuous assessment. Gastrointestinal effects. So ventilation increases our patient's risk for stress ulcers. So increases gastric acid secretion and things like that. So we do things, the main thing that we do to prevent this gastritis in our patient is to give them either a PPI or a H2 antagonist, right? You guys know these medications. We talked about GERD in previous classes. So you should know how they work and what their side effects are. Remember that they increase the gastric pH. Don't get confused with that. So as the pH is decreased, you get more acidic, right? As the pH is increased, you become more alkaline. So these medications work by increasing gastric pH, but they work differently. So understand how they work. Another GI complication is gastric distension. Remember, the epiglottis is not working properly. Upon intubation, the patient, we might accidentally intubate their esophagus, and then we ventilate their belly, and then we have to try again, right? Or the air might leak from around that cuff in the trachea, and the air might leak down into the stomach and cause gastric distension. So that's one reason why it's important to continuously assess the patient's return tidal volume. So we give them a set tidal volume, but the machine measures how much the patient returned of that. So we always want it to be at least that. We've been talking about 500. So if it's set at 500, the patient should be returning at least 500. Because if the return tidal volume decreases, what's happening? It's going somewhere, right? It's leaking. And it could be going into the stomach. It's heavy information in it. It's a lot to wrap your head around. So this is more down your alley, I think. Medication. So when a patient is on the ventilator, initially anyway, they will need some sedation because it's not natural, it's painful, it's very uncomfortable. So some patients do okay with this without a lot of sedation, but some patients are not very compliant at all and they have to be heavily sedated. So realize that when your patient is ventilated, they will need sedation and pain management. Sometimes they'll need paralyzation. We can paralyze the patient with medication. So let's talk about the sedation. You know these, I think Versed maybe, but remember that Versed is what type of medication? It's a benzodiazepine, so know that it works on what? GABA, right? And so know those side effects and things. So that's probably the number one medication used to sedate patients who are on the ventilator, Versed. So become very familiar with that medication. Propofol is a medication that can also be used for sedation when the patient is on the ventilator. And this is a good medication that can be used in a patient that has neurological problems. So they have a head bleed, they have a head trauma. Because the key thing about propofol is that it has a very short half-life. So as soon as you turn it off, the patient really begins to waking up very fast if they have normal renal function. the number one side effect of propofol. What is it, Jan? Hypotension. You worry about blood pressure when the patient's on propofol. You maybe have seen this before. It's white. Okay, propofol is white, and it's white because it has lipids in it. So those lipids can attach to the side of the IV tubing. So the IV tubing with propofol must be changed every 12 hours. Make sure that you write that down. Must be changed, or underline it. It has to be changed every 12 hours. There's increased risk for infection. There's also a risk for embolus, so that those lipids might become detached from that wall that built up on there. Maybe somebody was negligent and didn't change it for 3 days. So you have some buildup of lipids, and it could embolize into the patient. Not a good thing, right? So to increase the patient's comfort, we will give them some sort of pain management as well. So usually what you'll see ordered is Versed and fentanyl. All right. So fentanyl is a IV pain management or pain medication, and remember that fentanyl is 5 to 7 times as potent as morphine. So that's just keep that in mind. So you'll know that. So when you see it given at 100 micrograms, you're thinking, why are we giving so little? Well, it's because it's 5 to 7 times as potent as morphine. We always compare everything to morphine. Morphine is kind of a gold standard of narcotic analgesia. And also, what's the other one that's 5 to 7 times as potent? Dilaudid. Yeah, it's much more potent than morphine as well. So that's why you see it at very low doses, and it's administered in a continuous drip, just like Versed or Diprovan would be. And it is your nursing responsibility to titrate these medications too. So these medications, this order might simply say, start Versed at 2 milligrams per hour, start fentanyl at 20 mics per hour, and titrate to comfort. You can increase and decrease the dose based on the patient's response. It's a big responsibility. Okay? So that's why I say make sure that your patient is not over-sedated, because you're the one that is sedating your patient. Right? So make sure that they are not too sedated so that we can hopefully assess them for extubation. Sometimes, if the patient is non-compliant, if we need to preserve all oxygen consumption, or preserve the amount of oxygen usage, so if we want to decrease the consumption, we can use paralyzation. It's because by simply moving, we use oxygen. So if the patient is non-compliant or needs that, we can give them a paralytic. This can be given by a push, but usually if it's used for sedation, for mechanical ventilation, it will be given as a continuous IV drip. We wouldn't titrate this. This would be set at a set rate. But these medications work by paralyzing all muscle. The only muscle that it doesn't paralyze is what? Heart muscle. Remember that the diaphragm is a muscle. It also paralyzes the diaphragm. It paralyzes every muscle except for the heart. And remember that the brain is not a muscle, right? So the brain is still intact and working properly when the patient is on, when we give them a paralytic. So there's some key things that we have to remember. Make sure that the patient has an airway, because if we give them a paralytic, what are they going to do? Stop breathing, right? So make sure that we can ventilate them. This has happened, okay? More than you would imagine. I said that the brain is not a muscle, so therefore it doesn't paralyze the brain and make it stop working. So this patient may still be alert inside. So you have to make sure that this person is first sedated before they're paralyzed. So it's very cruel and unethical to paralyze a person who is not sedated.
Kind of freak them out a little bit.
I would think so, yeah. It would be as if you were trapped inside of your body and couldn't do anything. We'll talk about ALS, Lou Gehrig's disease, which is what disease is. But so this basically induces ALS, right? But it wears off. But these medications, there have been lots of studies done on them, and these have long-term neurological problems or complications. So these medications are not used very loosely. They're very conservative with the use of them and only used when needed. Often they're used during surgery, but they will use them at the least amount of doses, the lowest amount of dose possible. I mentioned some the nursing diagnosis of ineffective airway clearance. But here's some impaired spontaneous ventilation, right? So it's because the machine is in control, the patient doesn't have natural spontaneous ventilation. Ineffective airway clearance, mainly because of the presence of an artificial airway. And we talked about all those risks, barotrauma, infection, things like that. The patient is also at risk for having hypoxemia and hypercapnia if the settings are set wrong. It's a continuous assessment of these patients. Read this question to yourself. Don't shout the answer out if you already looked it up. This patient is getting Nexium, which is a proton pump inhibitor, right? So what is your highest priority related to the risk of damage to vessel walls by Nexium? So would you administer this before mealtime? No, that has nothing to do with this vessel wall, right? What about A? Who thinks it's A? Yeah? Well, it's an okay answer. But we don't dilute it in 100 milliliters of normal saline. We dilute it in about 5 to 10 milliliters. All right? Requesting from the pharmacy to give a PO form. Well, PO form would decrease the risk to the vessel walls, right? But it's not, you need an order for that. You can't just call and say, hey, I don't want to give it IV, give me the tablet. You can't do that, right? It's not in your scope of practice. So you push it slowly, right? The medication is diluted in saline, but it's a small amount. It's not 100 milliliters. Unfortunately, you guys can't give this medication at the mid. If you have given this medication at the mid, don't give it again, okay? Because it's an IV push. You don't give IV pushes at the mid. So it should be pushed slowly, all right? So I see some of you making faces. Don't give it again. Tell your instructor.
They'd be like, go ahead. He's like,
Yeah.
no, I don't want to.
That's a med policy, not a Southwest policy. So push slowly over 5 minutes. So I told you about Nexium. So this, I'm showing you that you need to know everything about these medications that I have told you to know about, right? So the proton pump inhibitors and the H2 antagonists, the sedation, the pain medication, and the paralyzation, right?
Some people have cleft tomorrow and the test on Thursday.
I'm sorry.
We didn't choose this.
You can wake up at 5 o'clock on Thursday. It's just the way it is. I'm sorry. Sometimes we have tests on Tuesday, and we have Monday clinical too.
It'll be my luck. I get switched to Mondays on that. I was hooked up.
Let's see. We need to cover this. So we'll talk about hypoxemia and hypocapnia, basically. So hypoxemia, remember that hypoxemia and hypoxia are different. You think about them together, but they don't mean the exact same thing. Hypoxemia, you think about the amount of oxygen in the blood. Hypoxemia, so PaO2 is the amount of oxygen that is measured on the blood gas. How much oxygen is dissolved in the plasma. The level of PaO2 tells us if the alveoli are working. Right? So some causes of low oxygen, hypoxemia, we're not getting air to the alveoli, we're not getting enough oxygen, diffusion is not happening properly. Remember, diffusion is how the gas goes back and forth, right? From the airway to the blood system, to the vascular system. There may be what we call a ventilation-perfusion mismatch. Maybe the capillaries around the alveoli are being perfused, but they are not being ventilated. Air's not getting there. Or Maybe air's getting there, but the blood is not being perfused around there. You have to have perfusion of the capillaries and ventilation of the alveoli to have adequate gas exchange. So there might be a ventilation-perfusion mismatch. Some disease may be causing it. So if the patient is hypoxic, they need oxygen. We need to get them oxygen somehow. Maybe this cause is pulmonary edema. We talked about that. We need to give them some diuretics and some oxygen, right? If the patient's oxygen level is too low, we may have to intubate them and put them on the ventilator and give them some oxygen and PEEP. Think about the FiO2 and the PEEP. These two settings affect oxygenation. So if we increase the FiO2, that's increasing the amount of oxygen we're giving the patient. That can hopefully fix hypoxemia. But we can also increase the PEEP level to improve oxygenation. PEEP and FiO2 change the oxygen level. Right? Make sure you know that. Let's talk a little bit about, we don't really worry about hyperoxemia, right? Not too much. Usually we worry when it's low. So let's talk about carbon dioxide. Hypo and hypercapnia, it's simply a definition. So you're more familiar with the PaCO2. So you learned that from those blood gases. So if the CO2 is less than 35, that's hypocapnia. If it's greater than 45, it's hypercapnia. Remember, normal range, 35 to 45. So here are some causes maybe of hypoxemia or hypocapnia. And we want to make sure that the patient is properly ventilating. To adjust the level of carbon dioxide in the blood, on the ventilator we would change two things, the tidal volume and the rate. These are the two settings that affect carbon dioxide mostly. The two settings that affect oxygenation mostly are what? FiO2, PEEP. The two settings that adjust or change carbon dioxide, rate, and tidal volume. So, for instance, if the patient's PCO2 is low, that might simply be because they're hyperventilating. They're breathing too much. They're breathing off too much CO2. So we would just decrease that rate on their vent, right? Or maybe get them calmed down for not ventilating. Slow their breathing down to retain some of that CO2. Hypercapnia, here are some reasons, right? COPD is a big cause, right, that you're familiar with. Make sure that you treat the underlying cause, especially for something like an overdose. You want to give them Narcan before you start doing a whole bunch of other things, right? Treat the underlying cause. And again, the rate and tidal volume. So these settings would be increased to decrease the CO2, right? The rate and tidal volume would be decreased to increase the CO2. Makes them hang on to more of it. By increasing them, we make them blow it off more. Faster, deeper breaths. Smaller, fewer breaths, right? Okay, we'll talk about blood gases next time. So this is where we will end for the test, right? So vents and oxygen and carbon dioxide. This is less than what they got last time. So. What questions do you have? It's a lot of information, I know, but welcome to adult health too. So you got to have some questions. Okay.
Make it a good one.
I get afterload. I don't quite get preload.
Preload. Think about EDV and preload being the same thing. Preload is the blood that's ready to be ejected. Basically, it's the amount of filling. Preload is the resistance, yeah. And if you read the actual definition of preload, it'll say it differently. It'll say the amount of pressure and stretch. But it goes along with how much volume is in there. It's stretching because there's more volume in the ventricles.
Okay, so increased preload is okay unless it's too much, because if it's too much, then you're stretching out the muscle and it's...
You can have fluid volume overload, yeah. Yeah, that would increase preload.
But high preload is okay as long as it's not too much, not in similar way. No, as long as it...
What's a normal CVP? Know that.
You know what?
No, normal CVP. Yeah. So the only numbers I'm going to give you might be a CVP or a cardiac output. Because, the cardiac output is 4 to 8 liters per minute. And CVP, let's just remember 2 to 6, about 2 to 6 or so. But generally, I'll give you scenarios, and I won't give you a whole bunch of numbers to interpret because that's not fair. I'll say it's high and low. That'll be easier for you. But know the normal CVP. Different references say different things about the levels of CVP. So 2 to 6 is okay. So single digits basically the normal CVP. That's right. That tells you about preload, right? Fluid volume status. Pressure on the right side.
I think that definition is
It is confusing, but it's stretching because there's more volume there.
right.
And the CVP is measured in what?
I think it's millimeters of mercury.
Oh, that's not fair. That should, I signed up.
That's what I took Saturday.
It happens. But that just means that you need to be ahead of the game and study.
I thought I was.
Yes, ma'am.
I'm trying to understand the concept of vagal tone.
Vagal tone.
It's really easy.
Vagal tone means, just remember that you may not already know this, but the vagus nerve, for our purposes for cardiac, affects heart rate and blood pressure. So increased vagal tone means that it's think of it as kind of a sturdy vagus nerve. You can't really stimulate it. Or if it is stimulated, it's not going to cause a lot of problems. But if you have a decreased vagal tone, it's more laid off. So if you have decreased vagal tone, it's weaker, so therefore it can be affected more easily. Does that make sense? No? Okay.
Like, is it constricting to increase blood pressure, or?
The vagal, it's a nerve. It's just a nerve. The vagus nerve. So don't worry too much about it. Just know that the vagus.
Thanks, after 2 days of Google.
No, I mean, so.
We were looking at atropine, that's why.
Yeah, we're trying to determine like medication.
Blocks the vagal impulse. Yeah, so it makes it. Just know that atropine, for our purposes in cardiac, increases heart rate. So study really hard.
Oh, I guess we'll do that now.
But remember that I talked about higher level questions and the types of things that you will be required to know. So in order to be able to evaluate something, you have to have a lot of knowledge base first. So you have to remember all this stuff, but you also have to be able to apply it and evaluate it. That's what's most important. You can know stuff all day long, but if you don't know what to do with it, it doesn't matter. So hopefully those test questions. No. We've got it. Yeah. So.
Okay, thinking about it, what's the difference? Sympathetic.
What's the question? Sympathetic tone. Same principle.
Okay.
All right. I guess y'all are done. Let me know if you have questions.
Mr. Seth.